testicular swellings we don't do because of this risk. So what do we rely on? We rely on ultrasound. A good ultrasound can pick up heteroechoic pattern, increase blood supply, and some people feel today that you can do guided FNA, but I am not suggesting that. The minimum biopsy therefore is high orchidectomy. And what is high orchidectomy? Again the same reason. We don't want to go through that's a scrotum, that's a disease. We don't do an FNAC because we don't want the disease to come here. This is draining into, this drains to inguinal lymph nodes. And testis drains to para-aortic. So we don't want to open up this channel. We do an ultrasound and we try to make a suspicion. We have a suspicion based on heteroechoic pattern, so it is increased blood supply, necrosis in the center, so hypoechoic patterning. That's what we do. So we do what is called a high orchidectomy. Which means we don't go through the scrotum to remove it. Same reason.
Yes.
So we will go through the inguinal approach. Clamp the cord with a soft clamp, deliver the testis out into the inguinal region. Don't go here, skin is left intact. And in the inguinal region only we will do the high orchidectomy after you've done. Not many people do this Chevassu Manoeuvre now, but if you want to do that, the testis is split into two after you put a clamp. But this is a soft clamp. Let's give it a name or a color. Soft clamp is green. And we opened it up and then we look for areas of suspicion. We opened it like a book. Areas of suspicion are sent for frozen.
Or imprint cytology.
Or imprint cytology. I have a video of Chevassu, I don't know where is it, that can be put. And you can see if it is malignancy, then replace it with a crushing clamp, which is blue. Take out the cord and the testis and send it first to pathology. Over. And if it shows it to be benign, we remove the soft clamp after you close the suture the testis back and deliver it to the back into the
scrotum.
So this is called Chevassu's Manoeuvre. Many people feel that it may not be necessary with the kind of imaging that you have. And the purpose is to get a diagnosis. And then based on that we find out whether it's a seminoma or non-seminomatous tumor. How does it matter, Karan?
Sir, the post-op management changes as per the histology, sir. Therapy, whereas
S for seminoma, S for sensitive.
whereas in non-seminomatous, sir, they are highly resistance will be less.
Non-seminomatous, they used to be called teratoma earlier.
Radiation.
Teratoma would be T for 20, 20s I used to get it. Seminomas in 30s.
They melt like snow.
And they melt like snow with
There is a
radiation.
bimodal distribution, 20 years and 60 years.
20 and 60. That's right. Now, non-seminomatous, mostly managed by chemotherapy, depending upon stage. We won't be discussing.
You can
You
do
watch
lymph
my
node dissection also.
YouTube video on that. So seminomatous, non-seminomatous tumors, and then the treatment would vary. That's why we need a high orchidectomy. Now, why do we need a high orchidectomy?
Sir, so that we don't involve the scrotal skin. So
We don't breach the sanctity of scrotal skin, which will upstage the disease. And if the lymph nodes in the inguinal region are involved, it will become a void disease. Clear?
Yes.
Any questions there? Okay.